Classical homocystinuria, also known as cystathionine beta synthase deficiency or CBS deficiency, is an inherited disorder of the metabolism of the amino acid methionine, often involving cystathionine beta synthase. It is an inherited autosomal recessive trait, which means a child needs to inherit a copy of the defective gene from both parents to be affected. Signs and symptoms: this defect leads to a multisystemic disorder of the connective tissue, muscles, central nervous system, and cardiovascular system. Homocystinuria represents a group of hereditary metabolic disorders characterized by an accumulation of the amino acid homocysteine in the serum and an increased excretion of homocysteine in the urine. Infants appear to be normal and early symptoms, if any are present, are vague. Signs and symptoms of homocystinuria that may be seen include the following: a family history of homocystinuria, flush across the cheeks, musculoskeletal, tall, thin build resembling marfanoid habitus, long limbs, high arched feet, knock knees, pectus excavatum and pectus carinatum. Mental retardation, seizures, psychiatric disease, eye anomalies, ectopia lentis in contrast to Marfan's syndrome, which features upward ectopia lentis. Downward dislocation is the typical finding of homocystinuria or subluxation of lens, myopia, glaucoma, optic atrophy, retinal detachment, cataracts. Vascular disease, extensive atheroma formation at a young age which affects many arteries but not the coronary arteries, intravascular thromboses. Laboratory diagnosis: the term homocystinuria describes an increased excretion of the thiol amino acid homocysteine in urine. The source of this increase may be one of many metabolic factors, only one of which is CBS deficiency. Others include the remethylation defects and vitamin deficiencies deficiency, folate deficiency, riboflavin deficiency, pyridoxal phosphate deficiency. In light of this information, a combined approach to laboratory diagnosis is required to reach a differential diagnosis. CBS deficiency may be diagnosed by routine metabolic biochemistry. In the first instance, plasma or urine amino acid analysis will frequently show an elevation of methionine and the presence of homocysteine. Many neonatal screening programs include methionine as a metabolite. The disorder may be distinguished from the remethylation defects in lieu of the elevated methionine concentration. Additionally, organic acid analysis or quantitative determination of methylmalonic acid should help to exclude cobalamin defects and vitamin B12 deficiency, giving a differential diagnosis. The laboratory analysis of homocysteine itself is complicated because most homocysteine is bound to other thiol amino acids and proteins in the form of disulfides via disulfide bonds. Since as an equilibrium process the proportion of free homocysteine is variable, a true value of total homocysteine is useful for confirming diagnosis and particularly for monitoring of treatment efficacy. To this end it is prudent to perform total homocysteine analysis in which all disulfide bonds are subject to reduction prior to analysis, traditionally by HPLC after derivatization with a fluorescent agent, thus giving a true reflection of the quantity of homocysteine in a plasma sample. Treatment: no specific cure has been discovered for homocystinuria. However, many people are treated using high doses of vitamin B6. Slightly less than 50% respond to this treatment and need to take supplemental vitamin B6 for the rest of their lives. Those who do not respond require a low-sulfur diet, and most will need treatment with trimethylglycine. A normal dose of folic acid supplement and occasionally adding cysteine to the diet can be helpful, as glutathione is synthesized from cysteine. Betaine is used to reduce concentrations of homocysteine by promoting the conversion of homocysteine back to methionine, that is, increasing flux through the remethylation pathway independent of folate derivatives. The reformed methionine is then gradually removed by incorporation into body protein. The methionine that is not converted into protein is converted to S-adenosylmethionine, which goes on to form homocysteine again. Betaine is, therefore, only effective if the quantity of methionine to be removed is small. Hence treatment includes both betaine and a diet low in methionine. In classical homocystinuria, The plasma methionine level usually increases above the normal range of 30 micromoles L, and the concentrations should be monitored as potentially toxic levels may be reached. Recommended diet low-protein food is recommended for this disorder, which requires food products low in particular types of amino acids. Prognosis: the life expectancy of patients with homocystinuria is reduced only if untreated. It is known that before the age of 30, almost one-fourth of patients die as a result of thrombotic complications. Society and culture: one theory suggests that Akhenaten, a pharaoh of the 18th dynasty of Egypt, may have suffered from homocystinuria. See also, cystinuria, hyperhomocysteinemia. References. External links: Homocystinuria support, Gene Review UW entry on homocystinuria caused by cystathionine beta synthase deficiency, paper and discussion on homocystinuria due to cystathionine beta synthase deficiency.